Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Okay, you guys, I had promised that I would read out a review here, and that person would be eligible for a 30-minute call with me. And I am pleased to announce that we had a review this month that I would love to share with you. Thank you so much, Marie Claire. If you're listening in, please get in contact with us so that we can arrange that 30-minute call from you. Marie Claire says, great resource. What a great resource tackling an ever-growing problem in our current work environments as physicians, both thoughtful and practical. Thank you so much, Marie Claire, for that review. And for those of you listening, remember, if you are enjoying the podcast, share this episode or share the episode that you loved with a colleague. The more we share, like, and subscribe to podcasts that we like, the more we get the message out to our colleagues that sustainable clinical medicine can be possible. So thank you all so much for your reviews. And if you are Marie Claire, please get in contact with us by email so that we can arrange that 30-minute call with you. Hello, everybody, and welcome back. Today we have with us Dr. Maire Daugharty. I'm going to let you introduce yourself to us. Welcome. We're excited for this conversation.
Thank you so much. I'm happy to be here. By way of introduction, I would say that I'm an anesthesiologist. I've been an anesthesiologist for the past 25 years. I decided to go back to graduate school in around 2015 and engage a master's in clinical mental health counseling with of opening a psychotherapy practice. I came to route. I actually went to medical school with the intention of going into psychiatry, but for a handful of different reasons, I opted not to go that route. I went anesthesia instead, which I have thoroughly enjoyed, with the exception of the burnout associated. I love my work, but there's just too much of it.
Interesting. Tell us more what burnout looked possibly for you as an anesthetist or as you're coming through your training. We can understand because everyone's experience is a little different, and you'll have other from some of the people you've been looking after too.
Absolutely. I lean into the burnout and depression because people often confuse the two, where burnout is actually a formally defined feelings that I develop over the course of time associated with work. There being too much work, there being too much exposure to trauma sometimes as part of it. I develop a sense of disconnect from my work, disconnect from my patients. I don't want to be here anymore. I start to feel helpless and hopeless about the work that I do. And I start to feel cynical. That's burnout as compared to depression, where there's some overlap there. Are separate and distinct entities. And I think it's important to distinguish those two because the approach to them are different. I tell people, if you're struggling with burnout, depending on how severe it is, that should be ameliorated by either backing off work or taking more vacation, versus depression, which takes a little bit of a different approach.
Okay, got it. Tell us about life as an anesthetist that was contributing to burnout for you and what you were experiencing about that.
Yeah, I will start by saying I'm still in my practice. I love my practice. The group that I work with, I joined them in about 2011. We go through periods where we are just very, very busy. We are either taking on new business or people decide to go elsewhere. So our practice shrinks a bit temporarily. Our hospital decided to take on a trauma 2 status at one point, and that was a real change. We were a small community practice, and most of us were there for that reason. And we all of a sudden started to take on more of a high acuity practice. And during that time, there were some changes in our staffing level, and we were very, very busy at that time. And I would also describe us as understaffed temporarily. And so it is that sense of always being on the hook. You go to work, you think you're going to be done at 2 or 5 or 7 or 9. And there's just always more work to be done. And at a certain point, it just becomes, you feel like you're on a treadmill. You don't feel like you're really engaged in patient care anymore, so much as just getting people through the operating room. And that is a terrible, terrible feeling. And I certainly landed in that spot where I was really struggling with, I hated to go to work. I didn't even want to talk to my colleagues. I didn't really want to engage with my patients, which is really uncharacteristic for me. And ultimately, I chose to seek a therapy process in order to sort out what was going on. I also felt a little restless with the practice of anesthesia. There was something more that I wanted. And of course, over the course of talking with someone about what I was experiencing and what I wanted and what I didn't want, I ultimately returned to my early adult interests in mental health and decided ultimately to kind of synergize those practices and still do one while I was developing the other.
Yeah, wow. Very good. Tell us about what it took to become your clinical mental health counseling.
First of all, it took a decision, which was maybe the most difficult part because I was well ensconced in a very stable practice. And the idea of jumping into something completely different was a little wild. Me and my husband and I had lots of conversations about that before he finally agreed to, and I finally decided it was the right thing to do. And ultimately, what I did was I thought about a handful of different options. I did interview with a psychiatry department and ultimately decided that a master's in counseling made a lot more sense for me
Mhm.
in where I was, both mentally and financially, and also my age. And really, what I wanted to be able to do was mainly to offer psychotherapy. And I applied to some psychotherapy programs and ultimately ended up getting into a hybrid program that worked really well for me to be able to continue working full time while doing the coursework over the course of several years.
Got it. Okay. What does it look like to do that work while working full time? Is this online
Yeah.
clinic work or are you seeing patients on your days off? How does that work?
Yeah. When I was in graduate school and in my supervisory period, I basically negotiated with my group to organize a consistent call schedule so that I was taking call very consistently. And then I would have a post call day off and I would have these predictable weekends off. Graduate school was hybrid. It was quite a bit online, but we would meet one weekend a month in person to process materials and talk about things. And I really needed to have predictability in my weekend call schedule in order to be able to make that happen. One of the things I told myself during that period was because it was really arduous. I mean, doing a graduate degree while you're working full time as an anesthesiologist is exhausting. But I told myself this is temporary. There's an end in sight, there's a goal here. And just like we do in medical school, right? You just kind of put your nose to the grindstone and you get it done. And then once I finished my degree, I negotiated with my groups as my practice grew. I backed off more on anesthesia. And so now I work very part time in anesthesia and I have a full time psychotherapy practice. And that took me a handful of years from the point I decided to go to graduate school till where I am now.
Got it. Okay. Tell us about the what you were feeling as you were asking for stepping out of some of the anesthesia roles, because if
Yeah,
you've got a
yeah,
shrinking pool, your colleagues are kind of
yeah,
taking a bit more of that burden. Tell us
yeah.
what that took to do that for yourself within you.
Yeah, actually, what I did was I formulated a win-win situation. I wanted some predictability while I was in graduate school. I offered if I take call every Wednesday night, would that be fair in terms of an exchange? Meaning I would take more call than my colleagues. I would take call every week during the week, that on the weekend as well, which offered them more call coverage in exchange for some predictability. It's going to be every Wednesday night. That was my first negotiation. And then as I started to build my practice and back off on anesthesia, what I ultimately ended up doing was saying, I'll take weekend call, I'll take all of the weekends, I'll work all four. And then I have the week to do my practice. Does that work for you? And of course, nobody wants call on the weekends. That worked really well. And then ultimately, I backed off on my weekend call because as my practice grew, I needed to rebalance. And now I do 2 weekends a month and I cover occasional Wednesdays when my group needs help. And then I run my practice Monday, Tuesday, Thursday, Friday. And the way I navigated the idea of perhaps so called unloading more work onto my colleagues was I offered I'll take more work if I can have this piece here. And that worked for our group, fortunately for me.
Hmm. I'm sensing that you had already done a lot of work on the burnout before you dove into the clinical psychology training, mental health training.
I had had an interest in mental health for a very long time. And I said I was planning to go into psychiatry and medicine. I was attuned to the things that people struggle with in terms of mental health. Burnout was a really big issue by the time it was at the forefront of my life. I will say that in terms of the idea that physicians were in a high suicide risk category was coming more to the front. It was being more talked about. I certainly had personal experiences with that. I had 4 partners complete suicide over the course of my career. And so that was very much in the forefront of my mind. And one of the things I was interested in was, what can I offer for the physician population struggling with some of the same things I'm struggling with, so that we don't get to the point where we're jumping off the building
Mm.
specifically. That was one of my driving forces at the time.
All right, tell us about then what you've learned in your new role and new practice. Interesting that you haven't
Yeah,
gone and done psychiatry. You've gone
yeah,
and done the part that you wanted, which was the
yeah,
real psychotherapy part, but kept your doctoring. I'm really
yeah.
interested to hear what that's
Yeah.
looking, what you've learned.
It was a little bit, it took me a while to bring together the psychotherapy piece and the medical piece, because counseling takes a very different approach to mental health compared to the medical model. And there was a lot of discussion. And I will say in graduate school, there was some negativity around the medical model. And it took me a while to incorporate both pieces so that they worked really nicely and synergistically for me and the population that I work with. I have learned so much. I have learned so much. One of the things about psychotherapy is you're working with clients and learning about them, putting some of themes together to help them understand how that's contributing to the predicaments that we find ourselves in. A lot of it resonates because a lot of it is, wow, I felt that too. Wow, I had that experience too. But also being very careful not to impose my experience on the person in front of
Mhm.
me. People come in with their unique individual stories, and it's really keep your eyes open for that and not make assumptions that had similar, all the same. I have learned so much. Some of the commonalities I think is important to share is, we're all overworked, we're all underappreciated, we're all so very undervalued. And physicians are really unhappy. Now, not all physicians, there are physicians in wonderful groups who have a great practice. A lot of physicians are really unhappy because of the environments that we find ourselves working in today, which are so different from 30 years ago when I trained.
Tell us some of the factors that things that have helped physicians within your practice kind of move back into a more, you said
So,
some aren't experiencing that level of
yeah,
intensity with regards to the overworked and underappreciated. Tell us more about how you navigate that.
I would say one of the things that comes up frequently, I use the formal term boundaries, but people come in with the fundamental idea that they have no choice about where they are. I am so unhappy. I'm working so hard, but there's nothing I can do about it. I'm exaggerating a little bit, but not
Yeah.
much. First, sort of connecting with the idea that, where does it come from that you feel you have no choice in the matter?
Mm,
Where does it come from, the idea that you can't say no when someone asks you to do something that isn't in your job description? Where does it come from, the idea that you can't say no when someone's asking you to do something that's outside of the parameters of the time that you have dedicated to work? And medicine will infringe, it will infringe, 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 infringe. And as long as you say yes, it will continue to close down around you. And you are the only person that can say, no, stop, this is too much. And
mm.
you not only have the right to, you have the responsibility to maintain your own sense of self so that you can show up for your patients.
Yeah, I think that loss of sense of self or loss of autonomy or feeling
Yeah.
trapped or stuck is a really big deal.
Yeah. Yeah, huge, huge. And that loss of autonomy piece is not theoretical. I mean, I remember in training, the attitude in medicine in the 90s and early 2000s, very different from today, where our autonomy has essentially been transmuted into something, we're employees in a system where our values often don't really align, which presents some real challenges.
Yeah. And we're seeing that everywhere, even just the appointment length, number of patients you have to see today. Even
Yeah.
what might look like little things make massive differences when you're working in that. Yeah.
Oh, 100%. Yeah. It takes the critical piece that is satisfying in medical care out of the equation, which is the relationship. with your patients, right? As a doctor, it is the relationship that makes the work so rewarding. And 10, 15, 20-minute appointment time for, very simple or very complex patients just doesn't allow space for that.
Yeah, yeah.
Yeah.
Tell us, how did you set up your business side of things? Are you by
Uh-huh.
yourself? Are you within a group
Mhm.
doing your psychotherapy? Tell us how it looks to be
Yeah.
within your psychotherapy world.
Yeah, I am a solo practitioner. I was very deliberate about that because I wanted to reclaim all of my autonomy, right? So I gone from a fairly autonomous anesthesiologist to sort of following all the guidelines that are imposed upon us, whether they make any sense or not. My practice vision was I'm going to open my own practice. I'm going to do therapy the way that I want to do therapy. I don't take insurance because I have no interest in kowtowing to a set of criteria from an entity that knows nothing about what I'm doing or the relationships I develop with my patients. So I'm fiercely independent in that sense. There are a lot of clinical therapists who open their own practice, but honestly, that leads to a lot of administrative work, which I'm not interested in. I'm interested in doing my own administrative work. So I follow my own billing, I do all my own notes, all of those kinds of things. And I'm happy to do that because that is a level of care that I want to provide for my patients, the people that I'm taking care of. I don't want anyone else to tell me how to write my notes, how many sessions are available to this person, and how I should approach their particular problem.
Got it. Yeah. Do you have a separate building for that? Are you online?
I am a hybrid practice. I do both in person and virtual. I will say that I prefer in person. The work
Mhm.
is more effective that way. Virtual is available, and that is particularly useful for people whose schedules just don't jive with my schedule and getting to the office. I actually rent out an office in a building that's dedicated to people who need offices. So there are
Mhm.
lawyers here, there are mortgage brokers here, there are laser tattoo removals here, and there are a handful of therapists in this building. And I just rent an office here, and it works out really nicely.
Very good. How long do you normally set for appointment length?
My appointment 50 minutes. When I work with couples, it's 60 minutes, but
Mhm.
basically it's an hour long appointment. In the 50-minute appointment, it's 50 minutes face to face, and then 10 minutes of gathering my thoughts, putting it down in a note, and thinking about the next person who's coming in. With couples therapy, it is on the hour. I don't offer longer sessions, although some clinicians do. I just don't feel like my ability to concentrate and someone's ability to really focus for a whole lot longer is reasonable for my practice.
Yeah, yeah. And if you're looking at what's currently offered in medicine with the medical
Mhm.
appointment and the psychotherapy, do you feel like there's elements of your psychotherapy that comes into your world in medicine?
Oh, 100%. Absolutely. I have always been a very attuned physician. I've always really attuned to the emotions that patients come in with heading into the operating room. That's a really vulnerable period. Having become a therapist to people's stories and really work to understand them and communicate things back, I am much more sophisticated in that arena. Likewise, in terms of navigating my colleagues, the operating room is a very socially hierarchical, can be very challenging environment, which I feel that I've always navigated very well, but my skills in navigating that arena are 2000% improved because of my understanding for how people interact, why they interact the way that they do. Yeah, absolutely.
We were talking about boundaries earlier. Have you been asked to start things like wellness groups for your group, or run group sessions or courses or anything
Yeah.
for your locals?
Yeah, so I've had some people tap me on the shoulder. I've thought about opening a group practice, meaning offering groups within my practice, but honestly, the logistics of doing that is really challenging. And I opted ultimately to work with individuals and couples around some specific concerns in my practice. And that's what I limit myself to. Always happy to present at grand rounds. I do that every now and again. I'm always happy to talks because I like to share information.
Mm-hmm.
I think that's really important, particularly from my perspective, having one foot in the practice of medicine and one foot in the practice of psychotherapy. I have no interest in engaging a wellness program in a hospital system. What they want and what I have to offer just don't really align.
Yeah, yeah. How does the medicine come into the psychotherapy?
I'm always thinking about, does this person have a formal diagnosis that would benefit from medication? How does their medical history interact with, I don't do a formal medical history, but if somebody's had a myocardial infarction or somebody has a chronic illness, that certainly plays a role in what we're working on in psychotherapy. When I'm prescribing medication for the things that I do, I'm of course cognizant of the other medications that they're on and the other illnesses that they have that may interact in a way that guides my decision making. The physician piece is really important in that arena.
Got it. All right. Tell us who should be thinking about doing psychotherapy? What are the types of therapies available from your perspective?
Yeah,
Just to give us a bit of a through the doors of a psychotherapist.
yeah. Yeah, that's a really good question. That's a question I've thought about a lot because I offer coaching as well. And what does somebody come in for coaching for versus what does somebody come in for psychotherapy for? I will say one of the things I see not infrequently in social media is I want to coach where really a therapist is appropriate, is more appropriate. And the
Mhm.
distinguishing feature for me is if you're feeling a little bit of burnout and you want to figure out some strategies, coaching is great. If you
Mhm.
are really unhappy, then you probably ought to lean into more of a psychotherapy mode because the unhappiness is going to be that's going to generate a lot of work. And I say that from experience is that's going to there's some unpacking to do there. That's how I distinguish it. Certainly if you have a medical diagnosis, you need to be working with a psychotherapist. Coaches can't work with a medical diagnosis, psychotherapists can. If you have major depressive disorder that needs treatment, a generalized anxiety disorder that needs treatment, ADHD that needs treatment, that's going to be the role of a medical person or a psychotherapist and a medical person. That's how I distinguish it in my mind. If you're somebody who needs work on boundaries, if you're somebody who needs work on conflict management, in my mind, that's really good work for coaching. And that's how I distinguish my practice.
That's helpful to help us might be the difference there. Can you
Yeah.
help us tease out what is CBT versus
Yeah.
EMDR, other types of specifics that you'll be using?
There are, first of all, an alphabet of models. It's very confusing to the general public. There's CBT, ABT, ACT, REBT. What is all this stuff? I divide therapy into two fundamental different approaches. One is cognitive behavioral therapy, and the other is depth therapy. I am a depth therapist. The way I distinguish them, depth, interested in your distorted thoughts, holding those up for you to see, challenging those, but I'm also really interested in where did those originate from. It's a very developmental model. It leans into deep understanding of how the brain develops, how implicit memory contributes to the assumptions that we make, the expectations that we have, and how those may or may not get in the way of our relationships or advancing at work or whatnot. The other separate thought process in terms of modalities, a lot of people do what they call trauma work. I'm of the perspective that all therapy has some trauma work fundamentally associated with it. EMDR, for example, is a fundamental trauma modality. It movement desensitization and reprocessing, and it is a way of leaning into the memories that may not be connected in the way that they should, because in traumatic experiences, one experiences overwhelm and the frontal lobe just falls off. So memories are not laid down in a way that you can pull them back and remember them and talk about them coherently. And so EMDR is a way to pull some of those threads together and lay that to rest. Then there's some addiction specific modalities like motivational interviewing, which is a little bit of a different approach compared to all the rest.
Got it. Okay. Yeah. Fantastic. Thank you for that. Tell us about some of the patients that you've been looking after within psychotherapy. Have you been looking
Yeah.
after physicians and clinicians, and what sort of themes are
Yeah.
people coming to you for? Is there still a stigma with regard to their concern about loss of job by seeing a
Mhm.
psychotherapist?
Yeah, yeah. I see a lot of physicians. I have a fairly diverse population of people who end up in my office, but I do see a lot of physicians. There is absolutely a concern for how is this going to impact my license? Can we avoid a formal diagnosis on the chart? I feel very like there's something wrong with coming to ask for help is a not uncommon
Mhm.
approach. We do talk about the impact of psychotherapy on it's part of the reason that I'm a cash pay practice is not only do I not want the insurance company to tell me how to do my job, but cash pay sort of changes the way I'm obligated to do my notes. I have a little more laterality there. So we have that discussion and decide how do we want to approach this? If somebody has a formal diagnosis, do we want to, is this what we're working on? Is this what you want on your chart? Or do we want to work with something a little more generalized, which we capture as a Z code? So, problem with the environment or phase of life transition issue. So there's many different ways to approach how one wants their psychotherapy to be documented, with the exception, of course, is that when things happen, they need to be documented, and I don't have control over that. So yeah, people generally present with complaints of burnout, complaints of I'm really unhappy at work and I just don't know what to do. Sometimes complaints about, my intimate relationship is falling apart and I don't know what to do. So really the gamut of, although I will say physicians often do present with work-life balance issues, to put in a catchphrase.
Mm-hmm. Yeah, yeah, we've talked a lot about work-life balance in
Yeah,
this
yeah,
podcast, and also because it's just so important. Because, like you
yeah,
said, most physicians and clinicians are overworked, and they're
yeah,
doing
yeah.
a lot, not just on the work front, but also on the home front.
Yeah, yeah. Well, and it's so hard to do both really well when this one is so demanding, and then you come home and you just feel like I don't have anything left to be, a partner or a parent or a sibling or whatever.
Yeah, and sometimes that's you still need to step into that role at home because
Yeah,
once people won't be fed and things. Okay,
yeah.
tell us, what haven't we spoken about that would be really important to talk about today?
I would say, I think one of the most important things is there is no shame in asking for help, even though that is very opposed to the message we get in our education and training. Our education and training drives into us that we show up, we ignore our own needs. We often go hours without eating, drinking water, going to the bathroom. We're sleep deprived. That is ingrained in us. And the reality is, we are people, and our most important instrument that we bring to work, regardless of what kind of medicine we practice, is our self. And so our self should be valued in that way. And coming to psychotherapy is one way of really beginning to value yourself. And I think anything I can say to mitigate the stigma associated with that, people don't go to therapy necessarily because they're falling apart and living under a bridge, et cetera, et cetera. People come to therapy for all sorts of different reasons, all of which are valid to process and all of which can potentially lead to life-altering ways of thinking.
Hmm. Do you think that we should receive psychotherapy education as part of medical education? Do you think
Absolutely.
it's okay?
Absolutely. Yeah,
Yeah.
100%. I think it would be really difficult to introduce because some of the values don't align. There's some cultural shifts in medicine that would need to happen in order to make that work really, really well. But absolutely, I think that would be a phenomenally positive change. Yes.
Mhm. I know that doing coach training and some of the trauma extension of that, you start
Yeah.
to see what you didn't see before, in
Yeah.
terms of how to
Right.
interact with the humans and how to
Yeah.
help them move the needle on a situation. The other thing is, I don't know that we're all expected to go to therapy as medical
Yeah.
students, as doctors.
Mm.
It just seems quite interesting that we're expected to just survive this without the
Right. Right.
without the
Yeah.
debriefing, without the ability to chat through it, perhaps.
Yeah. Well, and I think one of the most dangerous things we learn in medical school and training is compartmentalization. We're exposed to trauma on a regular basis over the course of a career, and we learn to pack that away. Somebody dies suddenly in the operating room or in the emergency department. And I mean, it feels terrible, right? It feels terrible, but we put that away because we have another patient to take care of. The problem is we don't learn to pull that out again and feel it and talk about it and process it and make it part of who we are. Right. So we split it off, which is just so extraordinarily unhealthy.
Hmm. Yeah. How do people find you if they're looking to learn more, reach out, or see you in a grand round or something?
Yeah, I have a website. People find me through my website. I post on social media. I'm very careful about my posting on social media. I'm usually posting to offer information. I do a fair amount of writing, and I publish on my website and through Kevin MD, which is a platform for physicians and other healthcare workers to kind of share some thoughts about. And I am frequently sharing thoughts about, what does it look like to be burnt out in medicine? What are your choices around that? What does depression look like? What are the issues around treating ADHD, et cetera, et cetera? And people can find me either on social media or through my LinkedIn or through my website and word of mouth.
What is the website?
It's my name. So it's mdaugharty.com.
Okay, perfect. Thank you. Just so that we're
Yeah.
aware of that. I will link that in the show notes as well for you with your
Thank
other
you.
ways to access, but just important for people if they're listening. Anything else before we leave? Something else, anything that we didn't talk about that we should talk about before we end today?
Well, we covered so much and I could talk for hours, but I think we covered a really good amount of material, and I would say I don't have anything to add.
Okay, perfect. Well, thank you so much for being on the podcast with
Yeah.
us today, and we'll let you go and have a great week, everybody. Bye. Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have Charting Champions for physicians and Smarter Charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.